All right. Good evening, everyone. As you are entering the Zoom, we are so excited to have you. This is our second night T4D partnering with the University of Illinois College of Medicine Urban Health Program. Thank you for joining. We're going to give you a couple of minutes because the numbers are increasing. I love seeing this part of the Zoom when more and more students are coming in the room. We are excited to bring you a great conversation tonight. We're not just going to have a panel where we're sitting out here kind of preaching at you, but really we want to share some experiences tonight. In particular, tonight's webinar is focused on a couple of hot topics that I think as students, hopefully as future healthcare professionals, that you may have some interest in hearing our stories about. Particularly tonight, we're going to talk about healthcare in the time of COVID-19, the pandemic, and its impact on Black and Brown communities. And there she is. Dr. Biggers is on camera. I love it. So I have got a group of 4 amazing physicians that I'm going to allow to introduce actually themselves as I ask them each kind of an opening question. But first, introductions for me. My name is Dr. Cameron Matthews. I am one of the founders and co-directors of the Tour for Diversity in Medicine. We have been having programming initially face-to-face, but of course now virtual since about 2012. And there's a group of about 40 of us that just absolutely love doing this, connecting with students around the country. And so we are eager to have these conversations in this forum as well too. And tonight's conversation is going to be equally successful. Last night we did an amazing panel focused on a great deal of successful tips on how to be a strong applicant to get into healthcare profession school. And tonight we are going to talk a little bit more current events, a little bit more about the medicine that we practice and our lives as physicians in this new space, this new COVID-19 space, this very weird new normal, as we're all calling it. So first, I'm going to let her highlight a little bit of her experiences. Dr. Amira Hamid is there at Cook County and is, I'm sure, having a hell of a time over the last year with the pandemic. What was it first like? I mean, we're a year in now, right? What was it first like when you started realizing what was happening, what was coming in to your emergency room? Did you like have a gut reaction to just like being in the middle of it?
Did I? I think so I had actually just had my daughter. So I had returned from maternity leave after having a couple weeks off and got back, and I'm not an avid TV watcher, so I didn't really know what was going on. But when I got back to work, everyone had on masks, even the patients that came in with abdominal pain, all the nurses had masks. But I remember going up to someone and I said, "Well, what's going on? Why is everyone having a mask?" And they said, "You didn't hear about what's coming?" I said, "What's coming?" Anyway, I went home that night, looked it up, and saw, everything that was happening in Italy. And then I saw like the red alarms going off in New York, with New York basically going ablaze. And then the next day, that's kind of when our disaster response here in Chicago started revving up. And I can tell you that there was a ton of anxiety, a ton of stress, especially as you saw healthcare workers were getting sick, some of them unfortunately dying from COVID, being exposed at work or either in the community. And there was so much information that we didn't know about COVID that I think everybody was kind of incredibly stressed. So suddenly the scariest, I'm an emergency medicine physician. So some of the scariest complaints are like, critical shortness of breath, patients that are blue, shearing chest pain going to the back. All of those set off red alarms for emergency doctors. But now, the scariest symptom was like runny nose or cough. So we did our best to prepare for it. We had a lot of changes within our department, going from, everyone wearing colorful scrubs to everyone just working quietly, kind of under a cloak of fear, honestly, wearing all of this extreme PPE, hot and sweating. It was a complete change in our work environment. But as the pandemic continued on, I think that we got a good hold on it. We became more comfortable with combating COVID as we learned more about it, and ways to protect ourselves. So that's my answer there. And to introduce myself, I'm Dr. Amira Hamid. I am currently an attending emergency medicine physician at Cook County Hospital. There, I am involved with EMS. I'm the Assistant EMS Medical Director for Chicago West EMS System. That encompasses medical care for the Chicago Fire Department and Hatsala EMS. And I'm also involved with education as it relates to structural racism and also initiatives related to social justice. I'm also a mentor for Tour for Diversity and very happy to be here to talk to you guys today.
Love it, love it. She's a beast. Okay, all right. So let me keep going on the emergency track though. Dr. Garth Walker, you are kind of in the midst of not only as an emergency physician, please definitely introduce yourself and tell everybody a little bit more about yourself. So you're seeing kind of the same things that Amira did, but you've also kind of transitioned into more of a like policy role, right? Which is kind of understanding kind of the public health perspective of how the city is making decisions and the state, and actually tell the students what you do and tell them how you've had to help make decisions more than just like a patient at a time. You're actually helping Chicago with their response.
Thanks, Cameron, and thanks for having me. It's great to be around so many familiar faces, Alana, Amira, and obviously UIC. You don't get opportunities like this often. So, hi everyone, my name is Dr. Garth Walker. I am an assistant professor at Northwestern. I practice emergency medicine, also at Jesse Brown VA Hospital. And I'm the deputy director at Illinois Department of Public Health. I lead the Office of Men's Health, as well as director of strategic opioid initiatives throughout the state. So what does that really mean? Well, right now we're in COVID, so it means practically everything. Everybody's doing something not typically related to their job. I'm sure Cameron can empathize with that at her level, but it's much more external than probably what I'm used to. So it's a lot of communicating, engaging different communities, discussing kind of what the context of COVID is. When COVID first started, I was practicing and doing research. So most of my research was around social determinants of health, disparities, access. And one of the common conversations that manifested during that time was that any academic, any person that is familiar with healthcare disparities was not surprised in terms of what the first wave of results brought forth. I think what was trying was that just like the COVID virus, it seemed avoidable. Avoidable in the sense that a lot of the policies and structural drivers related to how policy decisions are made probably played a huge factor in terms of exacerbating healthcare disparities in terms of who died the most from this virus. So the first wave, one of the big articles was 70% of the mortality was African-American communities. Now, when you look at the data, Latinos are affected the most by positivity rates as well as mortality. They have the youngest age of mortality. And pivoting from kind of a role of clinically, where there's a lot of stress, every Black physician could empathize with the notion of how cathartic it is just to see your community represented with increased frequency of death, increased frequency of having goals of care discussions for families that were not necessarily ready for that, and thinking about how that overlays with the historical mistrust of the healthcare system in our community, and how Black physicians bear the brunt of that stress during that time. And then transitioning now to, well, not transition because I still see patients, looking at it from kind of a macro perspective of how vaccines are distributed. I can probably tell you, no matter what we do, there will be disparities just because we are competing against decades and decades of structural drivers at play. So part of it is anticipating that and working with what is currently throughout the state, community-based organizations, and how to be intentional and address those issues. And then also be innovative in terms of highlighting the opportunity that is. You know, our state's led by a Black woman, Dr. Ezike Ngozi Ezike. We have a progressive leadership in J.B. Pritzker. We have Black leadership across the board in criminal justice, Kim Foxx, Mayor Lori Lightfoot. So it's a nice time to, from a value and principle perspective, to be involved. But it has been unique in terms of seeing how the virus has manifested across different areas within our institutions. So I'll stop there and I'll transition to whomever's next.
Love it. Love it. Thank you for that perspective. I think it's important that doctors like you that have that perspective are the ones helping make decisions, helping figure out how we're going to respond, you know, as a state, as a city. So I thank you for being with the Illinois Department of Public Health. Dr. Portela, I am very interested in hearing your perspective. You are a pediatrician, you know, primary care, taking care of beautiful families. I love seeing your posts of your patients and everyone that you take care of. But how are you actually having conversations with your patients, maybe with their families, about this pandemic and about how, you know, they could be protecting themselves, how they, you know, are interacting within their communities? Are those conversations hard?
Well, yes and no. So my name is Dr. Portela, and I am a pediatrician and the chief medical officer for a community health center located in Logan Square. So we're primarily about 88% a Latino population. And it was all just very alarming at the beginning because we didn't work directly with a hospital. We weren't directly linked to a hospital. And so initially it was things as easy as not having enough PPE gear and not knowing when we were going to get it because other people were first in line. They had to go to the hospitals first. They had to go to the urgent care centers, immediate care centers. And so it was very overwhelming to, as a chief medical officer, try to find the equipment, try to keep my providers safe, and try to stay open, try to shift to telemedicine in a population that doesn't do really well with phones or computers. So it was a very steep learning curve. The providers complained constantly of all the change in policies. And then the patients, either they took it very seriously, which is great, or they didn't think it was real because we live in America. And when you are from a different country, America is the epitome of what you would think medicine and just everything great comes from. And so they just didn't believe that it could get as bad as it did. And so it was a struggle between trying to tell families that have generations and generations living within the same household to take care of themselves, because even though the children won't get, or initially we didn't think the children would get as sick, it could be something deadly to anybody above the age of 40 with high blood pressure and kidney disease and cholesterol problems and obesity, which so much of our patient population has. And once we shifted over to beginning to vaccinate, it was a struggle to convince these same people that were so afraid of this virus that the vaccine was safe, and that, well, I hear it has baby parts. I hear that they're trying to kill the old people so new people can be born. Like, I've heard it all. And so just taking their questions very seriously, even though as a provider, you're thinking, where did you get that from? But it's very real to them. And how do you dismiss that? So it's been quite a roller coaster.
Yeah. Yeah, no, I'm so glad you're there. I think that the conversations with families, I'm a primary care doc, in the primary care space has been so critical over the last year. So thank you for that. Dr. Biggers, I am so excited you're here. I love that you're here. I would love to talk to you more about kind of what we've all been touching on, but kind of the unequal treatment, right, of Black and Brown communities throughout this pandemic, and of course, not just this pandemic, but for, you know, hundreds of years prior. How are we supposed to address that now, especially as physicians of color in this space, right? We are all actively here to try to make a difference. Have you been able to make a difference? Have you been able to take any kind of proactive steps to address what's going on? Or is this just like a futile cause? Are we just sitting here like, oh, well, we're just gonna keep doing what we do? What do you think?
You know, that is such a loaded question, Cameron. Such a difficult question, but no, I don't think it's futile. I do think it is interesting how things shifted when the pandemic hit, and we shut down. How it was very cool, kind of cool to see, because I'm an epidemiology nerd as well, to see how we shifted from what our day to day to, okay, now we have certain floors, our COVID floors, how we shifted our practice in clinics, where we had certain slots for patients who we were ruling out for COVID, et cetera. And then, what do we do with our other patients, right? So just because COVID's happening, people are still having heart attacks, they're still having strokes, they're still in need of surgeries, et cetera, et cetera. I was fortunate enough to be in the hospital when this all first started and trying to figure things out, and being on we had COVID teams and we had non-COVID teams. So I ended up being on a no COVID team. Also because I just found out I was pregnant at the time. So, still having those relationships with patients, forming those relationships, having those conversations. It's been brought up. People have fears about COVID. They have fears about, when can I see a physician? Or I'm afraid to go see a physician because of X, Y, Z. We're still in the trenches. And I think that our presence is very helpful in making sure that, that we maintain those relationships with people. So I don't think it's futile, but it definitely has changed over time. And someone brought it up earlier, those challenges with patients not really, engaging with technologies the way that we want to, and then how to make sure that they're still on track too. So yeah, we still had COVID going on, but we still have those patients that we're trying to make sure that they're on track with their diabetes, high blood pressure, kidney disease, et cetera.
Exactly. Here's a fun, actually, I'm being facetious, fun part of the pandemic. Is anybody surprised that this entire year got politicized in some way, that COVID itself became political, that we're having debates on the news about whether it even exists or whether we should, you would think it would be about the science. But is anybody surprised, and have you had conversations with patients on the political side, not questioning, the data and the science and, other, I would say, more typical response to, proposed treatment or recommendations from their doctor. But what about the political side of this? I'll open that to anybody. Garth, yeah.
I think when you think about COVID, there are two common narratives, and when you look at and I'm sure everybody's aware of this data, but Democrats, 80 to 90% likely to take the vaccine. Republicans, roughly around 40 to 45%. And at the beginning, it was right in line with African American. But the reasons for why they did not want to take the vaccine were different. So Republicans, or white conservative or rural, the drivers typically explained were mistrust for the government, which would be similar, but also the politicized nature of some of the talking points, like it was rushed too fast, or included with some of the recommendations by CDC, since it wasn't necessarily a concerted messaging between federal government and leadership at the time. When you think about it falling along racial lines of Black and Latino, there are differences, but for African Americans and Black populations, it was mostly a wait and see. For every discussion that we've had, you would see people either get the information and make a decision that they want to take the vaccine, or maybe they were not going to take the vaccine and maybe they want some more information, but it was, maybe they wouldn't say the words directly around Tuskegee or Henrietta Lacks and some of the stories that we are aware of from medical apartheid and books that kind of discuss a lot of the reasons for mistrust, but it was based off of maybe a notion that maybe their a family member may have been describing some of the apprehensions related to those issues. So oftentimes we weren't doing a lot of discussions around why this very instance in time is different from all these other times, and also discussing who is advocating on our behalf, people like us right here on this panel, or National Medical Association, who's vetting the data and making sure that the trials are representative of our group, and making sure that people are aware that Black and Brown people are taking the vaccine in public, and sharing it on media and things of that nature.
Exactly. Any other thoughts, ladies? It's been, I think, a source of interesting conversations with particularly some friends of family members about either the vaccine or even monoclonal antibodies have come up. I'm like, how do you know what that is? Like, I'm having the most interesting conversations with people, and it's politicized. I'm like, you shouldn't even really. I don't. To me, it's difficult because we're not really used to having that level of conversation when it comes to clinical care, right?
Yeah, I honestly, at the beginning of the pandemic, I thought, oh, this is going to unite the nation. You know, everybody's going to come together, especially when you go to work and you hear or see on the news, everyone's banging their pots, you know, downtown Chicago and other cities in the United States, kind of cheering healthcare workers on. So I was like, yeah, everybody's going to band together and fight against this virus. But no, you know, but I think some of that blame falls onto, you know, our leadership at the time. I feel like if our president at the time had teamed up with Fauci and said, yeah, we're going to follow science, we're going to do, you know, what we need to do, I think that a lot of his followers would have followed suit. But since he was so, you know, just completely, it was a polarizing experience, and it was kind of a downplaying. And there were several instances in which, you know, we were told that, you know, this isn't as big as as everyone's making it to be. Everyone's just, you know, making this stuff up. Then you see people following suit and saying, oh, you know, I drove past this hospital. I didn't see people lined up outside, you know, and there are so many, and I can't blame, you know, the people that don't work in hospitals. I can't blame them for the confusion. I can't blame them for, you know, not believing that it's here and that so many people are being affected. Because like Garth was saying, there's so much mistrust that our government has created amongst especially minoritized populations. But amongst like its constituents in general. So it's like, what do you believe? And I feel like working in the ER, you know, I see it with my own eyes. You know, our patients come to us in the ER undifferentiated. So this is the scariest place to be. An EMS provider is probably scarier than being an ER doctor. But when the patient hits the door, you have absolutely no information about them. You just know what their leading complaint is. But that leading complaint could be, oh, my eye itches, and you walk in and they're achoo, achoo, you know, and their eyes red from COVID. You don't know what the patient's coming in with. So it's incredibly scary. And you're seeing, particularly at my hospital, serving a lot of our Black and Brown and Indigenous and underserved and patients that literally just hop off planes from other countries and say, hey, someone told me to come to Cook County because they told me you guys will take care of me here. Taking care of a patient population like that, you can imagine how heavily rocked our patients were, because these are the patients that are on the news that are dying from COVID. And still, our hospital wasn't overflowing to the point where we can't admit patients. Sure, there were days in which we're boarding patients, you know, for a long period of time in our emergency department, but were we like New York? No. But when you look at our patient population, a large percentage of that patient population that showed up to the emergency department was COVID suspicious or COVID positive, and our ICUs were overwhelmed, et cetera, so forth. So being in the healthcare field, you can see it for your own eyes, but there's such a significant mistrust and distrust of our government that I don't blame everybody for not being a believer in it, especially when you can't see it for yourself.
No, that's fair. That's fair. I mean, the question isn't really to point fingers. It's just to, I think, acknowledge that this was just a very different, public health. We all know that, right? But just what we've dealt with over the past year as physicians has been very different than what we're used to, what we're trained for, how we interact with patients, right? Um, Let me pause just for a second before we get into other questions. I definitely want to make sure the audience knows that they can drop questions into the Q&A. Please feel free to interact with our panel tonight, and we'll try to address as many questions as possible. We also have some people in the backstage answering questions as well too. But for now, actually, I want to ask Yolanda, if you don't mind posting the poll. We're actually going to be raffling off a couple of books to our attendees tonight. One of our friends of the tour, Dr. Sunny Nakai, wrote an amazing book called Pre-Med Prep that we'd love to raffle off to attendees tonight. So please click yes if you're interested after tonight's panel closes. All right. So while we're doing that, I think I want to get a little personal. If you guys don't mind, did any of you guys have any fear of getting COVID, like exposure, like, symptoms over the last year? And how did that change how you interacted with people when you left work, right? Like we can get, like you get in your zone at work, right? You can put on masks and goggles and all the different stuff. But sometimes it's a little different when you're with your people at home and everything. Anybody have any interesting of how this has just been, you've had to personalize a lot of what you've unfortunately been exposed to at work?
I
Yeah.
think that initially it was a time of a lot of concern. And so, especially being in the medical field, I could notice it once the kids were not going to school anymore. A lot of parents started doing like groups where somebody would take care of a group of children on Monday, some people on Tuesday. And I could tell even in the groups where they knew I was a physician, they looked at my poor daughter like, oh, maybe we'll catch her next time
Oh no.
because, what if? And of course, I would understand that people that would readily come over or she would go over there, I could tell that there was some hesitancy and it made me sad, but I understood it. Home and it's really hard to come home and not being able to say hello and had to go change right away and making sure that you didn't have any trace of going to work on you. And then I believe that probably towards the end of the year, it was just a lot of just COVID exhaustion. By that point, it's like, bro, I don't even care. I just give it to me already. I'm just so tired of all of this. And so it was just a combination of that all the time for me.
Completely. Um, I think I'm so glad you brought up the exhaustion part. How are you guys dealing with burnout? I mean, this is real. Like normally as physicians, we're used to a level of fatigue. You go through residency, you're like, oh, I can take this and everything. But the last year has been overwhelming, no matter what level of practice you were in. If you had to be at kind of the decision-making level like Garth and I, it's just overwhelmingly exhausting as well as being in the clinical space. How have you guys been dealing with that over the last year?
Yeah, so I just had my baby. Who's there? Zara. She's asleep now, but she'll be awake soon. You'll hear. Um, but when COVID first started, actually, it was kind of like you, Paula. Like I became a walking germ, and we had this lady that was coming to the house to watch Zara while I went to work, and she showed up, and you can just tell that she was like very jittery. She was wiping all the knobs and stuff. So I didn't feel like it was fair to potentially expose her, especially when she's showing that she's scared. So I let her go, and then I actually shipped Zara off to, that's my daughter, Zara off to my parents at 9 weeks. So I detached from her, which is crazy because once you have a kid, you have like these, you imagine that you're going to spend time with your kid, watch your kid grow up, right? See them reach these milestones, especially like in the baby phase that goes so fast. You just imagine mothering this baby. But, I had no baby. The baby was gone to my parents' house and I just saw her over FaceTime. So I didn't become a full-time mother until 5 months. So from 9 weeks to 5 months, she was gone. And then since then, I've been kind of coping by just getting to know her and enjoying her and spending time with my family, my close circle of family, people that I feel comfortable around, getting tested frequently. But now that I have the vaccine, feeling more confident to go around my family, and just being safe. That's how I've been coping, just being extra safe and spending time with the people I love.
Perfect.
I would
Yeah.
say I wouldn't have got another job. Just kidding. Or something. I mean, at first, similar to what Amir mentioned. So I live with my wife, my son, and then my in-laws. So we were in townhome. So I essentially ended up living in a separate apartment for, I can't even think of how long, 4 or 5 months. So it expedited our decision-making process to move, and then just kind of how to cope with it during that time. Is you just have all these different types of feelings and sentiments, I think, running through you, whether it's from your family, whether it's from just seeing the patients, and then as you mentioned, just like the decision fatigue. I remember so early on we had so little information on how to treat this disease. We were like talking early innovation. Now we're trying to stave off intubation. And I remember having discussions with leadership about clinical management and things of that nature. And that was tough when you just kind of overlay kind of adjusting to new changes to your clinical environment. And then at the state level, just kind of all hands on deck for all types of things that are not necessarily in your scope. So on the flip side, the positive side is that you're gaining experience and you're just you're learning as you go, just like how medicine is for everybody. But I think it's challenged a lot of us to re-examine what we truly value and how we want to manage our time. And I think the work from home piece and having a son, that's been kind of a silver lining, because I've been able to see a lot of his milestones that I probably, frankly, might have missed once if I was just completely going in all the time in clinic, on the clinical standpoint. So there's been some silver linings, but also just new stresses that we just have to continue to re-examine how it's affecting our day-to-day.
Alana.
Yeah, I would say it's been difficult to cope with. I had just found out I was pregnant when all of this hit. And so that was an extra added fear because we didn't know much about COVID and we didn't know how it affect pregnant women. They were saying things like, oh, it doesn't cross the placenta, it does, et cetera. So that was extra fear. So I definitely went into mama mode and tried to protect myself as much as possible, being smart and being safe. So, we actually switched a lot of our clinics to telemedicine. So that was very helpful. And then also, while I was on inpatient service, making sure that I came home, I, scrubbed down, I didn't touch my face, all of those precautions as well, to help with mental health types of things. Going on walks just helped, with my husband, trying to try to stay as healthy, quote unquote, as possible, food you eat, et cetera. I would say that it though I missed out on things like traveling, like a baby moon and all of those things, the upside of Garth mentioned it, being at home and not having to work always in the clinic and sometimes being at home as well has also been helpful in terms of mental health, carrying a child, delivering a child, and seeing these milestones as he's progressing right now too. So yeah.
My goodness, I'm so glad that all of you have made it through and are able to even have a conversation with us with smiles and because you've all done so much while having families, while having a life. I mean, this is one of the pieces that I think it's good for students to hear, that you balancing your work life and your personal life is such a critical piece. And so thank you all for sharing. Let's switch up a little bit. We've got a bunch of students, a bunch of future healthcare professionals that want to hear your stories, and I think it's great perspective that you've given them about the work you've done over the last year. But how do you think the pandemic itself is going to affect how students coming into medicine are either going to be perceived or even trained, right? Because right now there's so little face-to-face opportunities for a lot of the students that we work with. Where do you see this going? Should students still be hopeful, or is this like going to be difficult for the next couple of years getting into professional school?
Well, we ended up switching a lot of our practice. We kept it 50-50 as far as seeing patients in person versus telehealth. But we did stop, obviously, taking students. And I thought that that was really unfortunate, because I think that that's what they needed to see the most of. That's when you really know if this is what you want to do for a living. Because people say that as a doctor, you're going to give so much of your time, you're going to hold your bladder. People aren't always going to appreciate what you do. But it wasn't until COVID hit that it was really life or death. You this because you loved what you were doing. And I think that the world saw a need, or at least this country saw a need, for having more physicians that look like the patients that they were treating, so that there could be more trust within the community. I think it really showed the distrust that some of these patients have in the medical profession. And I do hope that that leads to more populations that aren't heavily seen in medical school applying and being accepted.
Perfect. Well
I
said.
think, I think to add on, in the same vein, it does highlight the value of diversity. I think oftentimes people try to, nobody really anchored on what is the true value of diversity. And when you think about universities, you think about academic institutions on how people make the value proposition, and how insulting it is that you have to make a business proposition for diversity. You saw it these past several months, right? You see healthcare disparities, and you're wondering who's leading on that front. If you had a residency that was homogenous, you missed out on a leadership opportunity. I think that's full stop. Like, you did not train somebody that was going to speak to the issues that were at bay and push to the forefront during this time. So places that were uniquely positioned, I'm sure UIC was there because they tend to train a lot of diverse physicians, had people leading on this front. And when you want to have a supply of physicians that want to treat patients of color, as well as highlight issues that can offset some of these social and structural drivers that are at play, and not necessarily positioning vulnerable populations to be prepared against a pandemic or epidemic. You have to train diversity. You have to put a priority on it. And that's why organizations such as this, organizations such as CHAMPS, or you name it, urban health program that are centering Black and Brown medical applicants are so important.
Yeah,
And I agree more. That's why we love doing this. Amir, yeah.
To piggyback off of all of that, I think that for AdComs, I saw that question. I think we're answering that one, but I was like, what is AdCom? So I Googled it, and Urban Dictionary popped up. It says the evil gatekeepers who prevent you from starting the rest of your life. That's what it says. Anyway, I think AdComs would be more thoughtful and intentional about diversity and inclusion and what that really means and what that looks like, especially if they have people of color that are on the staff there or faculty there that can help like create that vision that they want to see. I think there's also been a lot of creation of pipelines or beginning development of pipeline programs for BIPOC students to get into leadership positions or either positions within medicine. And I think that the students, of course, like Paula was saying, a lot of the programs, they stop taking students or it's very hard for them to get experiences. So unfortunately, I think that you're going to have to work a little bit harder to get experiences or be creative about the experiences that you can get. But hopefully, I think that this has kind of opened the door to the lack of BIPOC medical professionals within this area. And I think that moving forward, people will be more cognizant about that and issues that affect our patient population. So I think it's going up from here. In my thought, that's my thoughts.
Yeah. And there actually was, I think everybody can Google it. I've been referencing it a lot. There was a USA Today article about increased Black and brown applicants into medical school just this past fall because of the pandemic, because we'd been in this and there's increased interest in wanting to be part of the fight. So to me, that is exactly the type of student that needs to get into our medical school classes and join us, because they're the ones that aren't scared. So I absolutely love it. I'd love to hear. I think I want to, open it up again. Students, please drop some questions in the Q&A and everything. But I think I want to do a little bit of a round robin because you guys gave great introductions and everything. But I want them to get to know a little bit more of you as we come to the end of our hour. So I'd love to hear, particularly where you're originally from, what your tie to Chicago is, more than just you living there now. And how you chose your field of practice, and what makes it stand out. Let's try to sell our fields, and I'll go last. Alana, go ahead.
That's unfair because we're in primary care together, but that's okay. I am from Atlanta originally. My original tie to Chicago is actually my mother. She grew up in Chicago. So I spent all my summers here as a kid. Growing up, she was a teacher. So, she got June through August off. And so we would spend that time here with grandma and family, et cetera, et cetera.
So you got Chicago in the summertime.
Yes, I had Chicago. So I was actually like, oh, I said I was going to the University of Chicago. It's going to be great. Got in, came here for spring break. There was like 8 feet of snow. I said, oh no, this is not happening. So did not go to University of Chicago, went to Furman University, which is in Greenville, South Carolina. Great experience. Glad I went. But ended up at the UIC, University of Illinois at Chicago for medical school. My grandmother just randomly was like, oh, you're going there. And I was like, this old lady doesn't know what she's talking about, but sure enough, she was right. And I forgot what the other questions were.
Why'd you choose internal medicine?
Why did I choose internal medicine? So I was already kind of like-minded in internal medicine. I thought I wanted to do cardiology. I worked at the CDC in Atlanta for about 3 years in cardiovascular health, and went to medical school and ended up not liking EKGs, just random. And then I also knew that I wanted to combine a career with medicine in public health and with health disparity research. So went to to residency thinking, okay, well, I'm going to keep an open mind, right? Still cardiology was on the list, but open mind. But the thing that I found when I went to the different specialties was that I actually cared about the whole of the patient and not just that one body part, not just the heart, not just the gut, etc. So when it came down to it, got some research experience while I was in residency and looking for jobs. And it was a better fit for me to stay in internal medicine and also have a focus on health disparity research. So that's how I ended up where I am. And yeah, and it's awesome. And I love internal medicine. It has many different subspecialties if you're interested, not just primary care, but also if you're interested in working with your hands as well. So
Perfect, perfect. Dr. Portela, tell us about yourself.
So I was born in Colombia, South America. I came to the US about two. My parents for some reason picked Chicago, and so I was raised here. I was actually raised in Logan Square, which is the community that I'm practicing in now. And I did my residency at UIC. That's how I met Dr. Matthews. And when I was a child, I said, I'm going to do pediatrics because I do believe that I was a child. That's all I knew. And I thought that would be fun. As I got older, I thought OBGYN was very interesting to me. I love the GYN portion of it. And then the babies came out and they were so much cuter than having to go back and attend to the mom. And so I decided I am a pediatrician, and I am definitely the example of a pediatrician. I love my babies, and I wouldn't them for the world. I see children until they're 21. And about 10 years out, I decided that I wanted to go back and get my master's and then do more of the administrative side so that one, I could learn, because medical school doesn't really teach you the business aspect of medicine. And two, just so that I can have more of a reach into the community that I wanted to help so much. And so that's where I'm at now.
Love it. Dr. Walker.
So I have a unique story, but with respect to kind of getting into medical school standpoint. So I'm from Chicago, grew up in Chicago, pretty much identified myself as an athlete. I love basketball. Chicago Public School has a huge basketball culture. So that was kind of like how I defined myself. Also played football. When I made my college decision, I was like, which one has a sports team that I'll be able to play for? My first year I did football and track at Purdue University, and then I transferred to University of Illinois. The story that I usually tell is we were doing the Oklahoma drill, which is essentially when you have like a running back and like three linemen. I went head on and I had like a concussion, this crazy back injury. I was taking about 8 Advils a day just to get through spring ball. And I just remember being in my room, I was like, all right, I gotta open a book. So that's when I kind of got really into just being responsible to get good grades. And luckily I was pretty mature at the time. And I decided on medicine after I had done an internship. I was excelling in my sciences, and I taught organic chemistry, and it was to like a group of students who rural, inner city. And the beauty of organic chemistry is that it's the one subject that you don't have any exposure to. You can't take an AP course for it. So if you work at it, you can do well. And I used to see that in my students. And it got me interested in education. I did AmeriCorps. I worked for DC Public Schools, where we helped set up parent-teacher association organizations while I was applying to medical school. I was fortunate enough to test pretty well. And I got way more interviews than I ever anticipated that I would be able to get. I was between Northwestern and UIC. I ended up getting a scholarship in the urban medicine program, which tied me to UIC. I didn't know what social determinants of health was at the time, but my work was basically social determinants of health at AmeriCorps. And urban medicine was just an awesome program to be with the same individuals, of like-minded individuals that were interested in medicine, but just interested in the other stuff. And during that time, I was pursuing both orthopedics and emergency medicine. I had a fantastic medical school experience. I wouldn't trade it for the world. But I unfortunately didn't match the first time. The reasons why, I'm still kind of trying to explain to myself what those reasons are. But if I had to estimate, orthopedics was not necessarily as, I would say, progressive. I think I told every interviewer that I wanted to take care of Medicaid patients. And it wasn't necessarily as it was just a weird interaction in terms of from a specialty like that. Not saying that not everybody was on board, but it was just not as receptive to that as emergency medicine. After that time, I had interviewed at all the top programs, and it was a very jarring time to be kind of rejected and not necessarily, a program not really wanting you. But I had perspective in the sense that it was a really competitive specialty. When you don't match, the programs can tell if you don't match, do they rank you? So one of the programs that asked me to come was Pittsburgh, who I interviewed at. I did a year of research there. It was a very malignant time, very difficult time. And when you think about institutions and leadership and people that can't necessarily speak up, that was my experience at the time. Like, I could not speak up. I couldn't talk to anybody. I was afraid that there might be retaliation, so I quit. During that time, I pursued an MPH, and I was fortunate enough to have a Black physician look out for me. My older brother's a ER physician too. That's important to mention. Trevon Thompson really looked out for me, as well as Tim Erickson, Brad Bunny, and the UIC ER program, who really vouched for me. And I was lucky enough to get interviews without going straight through and without having kind of the traditional letters to pursue ER. And the ER has been a fantastic fit for me. You don't ask people whether they can pay, you just treat. You have a good perspective on public health because it's the first wave of what you see, what's wrong with healthcare, and you can still have some of that compassion. And I've been lucky enough to also just have kind of these unique opportunities in terms of working at IDPH as well, and continue to do research. So that's my story in the shortest period that I could tell it.
I love it. I love it. Amira.
I'm from the south side of Chicago, grew up off of 83rd and Drexel, also spent some time in West Pullman. My parents moved us out to Aurora, which is one of the western suburbs, and that's where I did high school. And from there, I took off to Jackson, Mississippi. So random, right? Jackson, Mississippi. I went to JSU, which is a HBCU down in Jackson. And I loved my time there. Honestly, it was like the best time of my life. Loved my HBCU. They poured into me. I just absorbed all of that love, all of that energy. They sent me every summer to do some research somewhere because there was a pipeline program. Or either they just really wanted their, students to do well, and they knew about the adversity we faced. So they made sure to push you to do research. So every summer I did research, and I had it in my mind that I was going to do MD, PhD. I always wanted to be a doctor because my dad was a medic in the Army, and just him, just explaining medic in the Army and being a medic in the Army and just watching movies and stuff, I just imagine myself being a doctor running towards the danger, right? Like saving lives. So always wanted to do that. So when I was in undergrad, I got it in my mind I was going to do MD, PhD because I was doing all this research. Well, I went to Northwestern, which is my third summer of research. And I had this mentor. I was working underneath her in the lab. Anyway, she went hard, okay? She went really, really hard. I mean, she was, hey, it's 8 p.m. Are you going to go back to the lab? Oh, no, ma'am. You want me to do what? No, to tap out peptides? No. So I told myself, I'm not doing I am not going this hard unless I'm going hard for patients, like actual human beings in here. So I went ahead and cut off the PhD and just decided to go for MD. No way. Anyway, so I ended up at UIC. I applied to a bunch of different medical schools. And
we still need Black researchers, though.
Oh yeah.
Okay. We do. Yeah. I see a question about MD, MBA. Hey, MD, PhD. Somebody out there. It's for you, okay? Not me. But UIC. I ended up actually going to UIC because of the urban health program. I wanted to stay down south because I just loved it so much. But when I went to UHP, I mean, I feel like I felt the love pouring in from UHP, and I got the HBCU feels like it was like a little community within a community. So I came to UIC, finished my education there. I was actually Garth's classmate. Garth is one of my closest friends. So shout out to Garth. But after finishing UIC, I had to, while finishing, I had to decide what specialty to do. And my brief story of how I decided is, okay, so I already got it in my mind that I'm running towards the danger. So I wanted to do a specialty like that. And my first rotation as a medical student, early third year, was internal medicine. And I just remember sitting in the clinic reading about hypertension guidelines and refilling diabetes medicine. And I was just like, this is not what I wanted to do. Not any shade, no shade to anybody that does that. There's joy in doing that, keeping your patients healthy, but it just wasn't for me. And after doing that clinic, I went to the floors, and now I'm on the floors taking care of patients. And I had one patient, I will never forget him. He's like etched into my mind, but I took care of him on 2 occasions. He came in, got discharged, came in again. And on the second time he came in, the team switched. So the doctors that were taking care of him, they switched over. I'm on a new team now. So they didn't know him. I knew him very well. And I just knew something was off because I was like, I took care of you and something's going on. You're not making sense. You don't look well, and I'm as a medical student, you don't want to, I'm trying to ring the alarm in a medical student way without burning bridges and without getting a poor eval. But I was like, hey, y'all, something's going on with him. Anyway, I was not believed to the degree that I should have been believed. And anyway, I stayed in the man's room. I was giving him cups of water to sip, like, hey, man, sip this water. Like, and anyway, someone came around.
Knew how to do to give him water.
Right. We're like, I was a rogue medical student as we're diuresing. I'm giving him cups of water, like, save yourself. But a team came around on him. I don't know what team it was, but they called a rapid response, which is the thing you call before a code blue, because they evaluated him and was like, this guy's sick. Anyway, they call a rapid response. X-ray shows up, they shoot a chest X-ray, his lungs completely collapse. And I'm like, oh my God, it's an emergency, and he's altered mental status, he's out of it. So they call the surgeons to come to bedside to drop a chest tube. They asked me to go get the tool. So I'm in the, utility room, I'm having a good time. Like, oh my gosh, I'm doing my first emergent thing, getting the tools. I come back, I get a good job for getting the right one. So I'm like, yes, it's maybe surgeries for me. I got the right stuff. Anyway, after they popped into this man's chest, like they're, cleaning off the site, popped into his chest with using a scalpel and like some of the forceps. As soon as they popped in, you heard a huge gush of air and he woke up. He was like this, out of unconscious. He woke up and he said, thank you, Jesus. And I felt my feet like start tingling and my lips started tingling. My fingers started tingling. Like my body was on fire. And I just knew this is for me. Whatever they just did, it's for me. So obviously it was an emergency, but it was also surgical as well. So I said, well, is it surgery or is it emergency? So EM and surgery. I did 2 surgery rotations to wrap my story up. I did 2 surgery rotations. The second surgery rotation, I went back because I wanted to do just trauma and just those emergent cases that came into the ER. And, I went down and there, I'm on the west side of Chicago at this hospital called Mount Sinai that gets a lot of heavy trauma. And, there's a trauma activation, code yellow to the emergency department. So I'm emergently going down. I get there and there's a patient and, it's a gunshot wound. He has no pulse in his leg. And if you're a medical student and you're reading about it and you finally see it, you're like, oh my God, it's here, no pulse, let's do something. So I'm getting the, I call up to the OR, we're coming up, doing everything they tell us to do, going to the pharmacy, grabbing the stuff, hitting the elevator button, holding the elevator, get in there. And it's in the middle of the night and it's so busy because there's so many trauma cases going that I am like first assist with the trauma fellow. So she's the surgeon operating and the only other person helping her operate is me. And then like there's a, a nurse, the scrub nurse that's in there handing you tools and stuff like that. But I'm the only person in the wound with her. So I thought to myself, oh my gosh, this is incredible. Like I'm first assist in here. I feel like a doctor, as a medical student. And the whole time I'm like, girl, if you don't close up this wound so we can go back down to the ER, that's where the action was. I'm tired of this, like, and then my back is hurting, it's cold, it's hot. We don't know what to do. It's how many hours are left? This mask is hot, So I told myself I did not want to do surgery and be stuck in some OR where my back was. After that, every surgery that wasn't, I traded it off. Hey, student, hey, you're a third year. Don't you want to go to this thyroid? Don't you want to stand there for 9 hours? So I got rid of all those surgical cases I didn't want to go into, and I completely wiped surgery off my list. And that's how I knew EM was for me. And I ended up going to Cook County because of the patient population they serve, like I already talked about, and that was my calling. So that's what I'm doing today.
You are brilliant. Oh my gosh, that is the best story ever and the best progression ever. I love it. All right, well, while we wrap up for the evening, again, thank you to our whole panel. Thank you guys for sharing your stories, for sharing your experiences over the year, for doing what you do every day, because you are truly saving lives and helping people in your communities. And for tonight, you're helping a lot of students that attended tonight. So thank you guys for your input. Students, please feel free, check us out, Tour for Diversity in Medicine. We are all over social media, Instagram, Facebook, Twitter, and everything. Follow us. We've got more events, including another on Thursday that's being advertised as well. And then don't forget, UIC is actually hosting a panel on Black Men in White Coats, the documentary movie. Garth, you're on that. So aren't you on that tomorrow? That's what I'm talking about. Garth is on the panel tomorrow. So we'll make sure you get that information.
UIC loves me this week.
Yeah, we love you.
We love you all the time, Garth. Come back.
Exactly. But thank you all for coming tonight and have a great evening. Bye, guys.
Bye, everybody.
Bye, guys.
Yeah, take care.
Thank you all so much. Amira, I'm still laughing.
Oh my goodness.
That was a good story.
It was,
That was
I actually didn't know
I
this
never
whole
knew
thing.
that.
That's how it happens.
Never do that. Thank you so much for sharing. And Garth, we'll see you tomorrow. Oh, he got off. Okay. Bye, Dr. Portela. Bye, Dr. Trevino.
All right. Good night, everyone.
Good night, everybody. Bye-bye.